thank you both for doing the February IIDR rounds, and welcome everybody who's watching. So our talk today is on one of my favorite topics, multi-drug resistant gram negatives. So our speakers today are Dr. Deb Yamamura, who is an associate professor in the Department of Pathology and Molecular Medicine and has spent more than a decade as head of the Bacteriology and Mycology Lab at Hamilton Health Sciences. She has an interest in fungal diagnostics and emerging resistance in both fungal and bacterial pathogens. And today she's going to tell us about having to treat a multi-drug resistant Acinetobacter osteomyelitis with Cephaderasol. I'm also pleased to introduce Derek Chan, who is a PhD candidate in my lab. And he is looking for new antimicrobials using biofilm stimulation as a reporter. He is investigating the gram-negative activity of thiopeptide antibiotics, which are, they have activity against gram-positives, but were not known to have activity against gram-negatives until recently. And today he's going to be speaking to us about exploiting iron limitation to deliver antibiotics across the outer membrane of gram-negatives. So thank you both, and I will pass the mic over to Deb.
Okay. So what I'd like to do is initially start off with a very difficult case that the Infectious Disease Service had to deal with. I'll discuss some of the second-line agents that we have commonly had to use, and then one of the newer agents, Cephaderasol, and then I'll leave it to Derek to talk about drug development and a little bit more about the science of this new class of drug. So this was a previously healthy 67-year-old woman who unfortunately fractured her left ankle when she went out to her garage to put her compost away. She needed an ORIF, and that was performed in February. Unfortunately, she had quite a complicated course with a PEA arrest secondary to pulmonary embolus. She then went on to have numerous complications at the surgical site. So within around 2 to 3 weeks, she developed surgical site infection with dehiscence and necrosis. And at that point, a wound swab grew both an E. coli and a pan-susceptible Acinetobacter baumannii complex. And she was started on a quinolone agent. She underwent multiple debridements, and then on March 22nd, had removal of some of the hardware. And because there was quite a significant soft tissue defect, plastic surgery had to put skin and muscle flap on the ankle. In April, her cultures now had an MDR Acinetobacter. She continued to have multiple surgical debridements, and they discontinued all antibiotics mid-April. She was then transferred over to St. Peter's on June 9th, and this was mainly for rehab. And looking at the notes there, she did have another wound culture that grew both the MDR Acinetobacter again, along with Staph lugdunensis. At this point, they were really concerned more about the skin and soft tissue flap. They treated this with chlorhexidine and felt that it improved. This table, and we'll come back to this as we get more information. As you can see that the initial Acinetobacter baumannii complex isolate was pan-susceptible to the ones that, to the antibiotic agents that we would use to treat Acinetobacter baumannii. And she really only had 2 days of Cipro and then levofloxacin. And within 2 weeks, this strain had now become multi-drug resistant. They did try a course of meropenem and Tigus Cyclin, meropenem with prolonged infusion, and then they stopped this at around April 17th. And at that point, the isolate was now even more drug resistant. There were other cultures that occurred when she was at St. Peter's, but as I mentioned, they sort of targeted the Staph lugdunensis, and she had no further treatment for the Acinetobacter. Unfortunately, while she was at St. Peter's, she had increasing pain, and she developed a soft tissue infection. And this is on the medial side of her left ankle. And as you can see, there's a fistula here that would open and close, draining purulent material. And on the lateral side, she was having, again, evidence of soft tissue infection of the soft tissue flap. Because of this, she was transferred to the Hamilton General on October 12th, and the orthopedic team was going to do a more definitive surgery with complete removal of her hardware. If you look at some of the investigations she had while she was at St. Peter's, you can see that the x-ray of her left foot showed extensive cortical destruction and erosive damage, and there really was non-union of the bone. And you can sort of see through here, really there's no defined cortex to the bone, and in here there was no bone healing. CT scan also showed extensive bony destruction, septic arthritis, and abscess, and a white blood cell scan also confirmed that there was deeper infection with osteomyelitis. So really she was an osteomyelitis and hardware infection at this point. So she had her surgery on October 14th, and they removed all the hardware, the debrided tibia, fibula, talus, did a synovectomy. And because there was actually a bone loss, they had to put in bone cement, but thankfully they didn't put any hardware. The tissue culture from the OR grew multi-drug resistant Acinetobacter. So our team became involved, and so the consultation was the day before surgery. And in typical fashion, it was, please provide antibiotic management, and can we put the hardware back in a few weeks? So that's where we're left. So let's take a look again at the Acinetobacter susceptibilities. So we, at this point on the initial consultation, we held off on all antibiotics because we wanted to make sure that the tissue cultures weren't going to be impacted by prior antibiotics. And then we're left with deciding what would be the best empiric regimen. So if you look back, we already knew it was very multi-drug resistant. We knew that previously the isolate, even though colistin had not been used, it had been sent, and the MIC was 0.5. So that was certainly an option. When you look at the Tigus Cyclin, this was reported as resistant, but we do know there's some limitations with the Kirby-Bauer method that's used in the lab. So these were considerations in terms of empiric treatment. However, we realized because it was such a deep-seated infection, which would require months of treatment, that we really needed to consider another agent. And a few additional things on October 14th, when we finally did get the susceptibilities back, you can see it is meets the criteria for XDR. Tobramycin was actually resistant. We sent off the Tigus Cyclin and colistin again to the referral lab, which is a public health lab, so they could have broth microdilution. And we do have some PCR assays, mainly for the Enterobacteriales, to look to see what carbapentanases are produced. And they were negative for these ones, but we only had OXA48 like, none of the other oxas. So it was quite a predicament. So what was chosen, even though the meropenem ended up being resistant on October 14th, it was greater than or equal to 16, and previously it was 8. So we thought we would still try the prolonged infusion with meropenem. We added colistin. Unfortunately, we had to discontinue this due to renal toxicity, which developed pretty quickly. And she also had CNS toxicity with hallucinations and change in mentation. We did try a very short course of gentamicin, and this probably did exacerbate a little bit the colistin, although the creatinine had already been increasing before we started that. And then when we ran out of the possibility of using colistin because of the side effects, we went with tigecycline with standard dosing. And I'll talk a little bit more about standard and higher dosing later on. But we realized we needed to have a more effective antibiotic that can be used long-term. And so we started the paperwork to get Cephaderasol, which unfortunately is not a Health Canada approved drug at this point. So now I'm going to backtrack a little bit and just talk a little on the epidemiology of Acinetobacter, some of the resistant issues, and then some of the treatment options. So Acinetobacter, if you look at the etymology of the organism name, it actually is acinetobacter, which means it's non-motile, but this is in fact a misnomer as it is motile. It is a gram-negative coccal bacillus. And the pathogenic species that play a major role in human disease are mainly Acinetobacter baumannii, but we also do see infection with Acinetobacter nosocomialis, Epidii, and there is an emergent pathogen in Asia called A. cerfedii, and these are all part of the Acinetobacter baumannii complex. Acinetobacter is very common in the environment, liking wet environments, soil, ponds, wastewater, and also moist tissue, and it has been found on a variety of different food products. If you recall back in 2003, XDR Acinetobacter made the headlines because soldiers, both US and Canadian soldiers in Iraq, came back with a very resistant strain of XDR Acinetobacter baumannii, causing soft tissue infection. And it is known that Acinetobacter can persist in very dry desert conditions. Interestingly, Acinetobacter baumannii itself rarely does colonize skin. And what makes this organism really difficult is it's very resistant to desiccation, which allows it to survive in hospital environments. And interestingly, ethanol can actually promote growth. It also is able to pump out chlorhexidine, and this ability both to withstand some of the disinfectants, along with being very hardy in the environment, has made it a very difficult pathogen in a hospital environment. So it has become an extremely important pathogen in the intensive care unit. And risk factors for MDR Acinetobacter include colonization pressures, the more the organism that's present, selection by broad spectrum antibiotics, which is not a surprise, trauma or surgery, any disruption of the skin, burn patients also are very susceptible. And because of its biofilm predilection, endotracheal tubes or any other sort of devices. As I mentioned, the persistence in the environment make it a difficult bug to contain transmission. It often from the environment will go transiently on the hands of healthcare workers and is then passed on to patients. But there have also been some studies where they have actually shown that aerosolization directly from patients that have MDR Acinetobacter has resulted in this organism in air sampling up to around 25%, and has felt that this actually can also result in transmission. I'm not going to go into virulence in a great detail. It is a great biofilm organism, has adherence of virulence properties, and sort of an interesting one in terms of iron acquisition is that with its siderophore, it is actually a very effective iron scavenger, which makes it a difficult organism again. So in conjunction with its persistence in the environment, one of the other factors that makes it a very difficult organism is the resistance and how rapidly it develops. So this rapid development of resistance has made it a very difficult organism with very high morbidity and mortality. And because the empiric choice of antibiotics can be quite difficult and limited, we know that if the wrong choice of antibiotics occurs, and it is an XDR strain, the mortality can go up to around 70%, so very significant. What is really difficult about this organism is it has some inherent qualities which make it less susceptible to antibiotics. One of these is that it has a small number and very small size of porins, which reduces its permeability to antibiotics. And if you compare it to Pseudomonas, the permeability diffusion rate of Pseudomonas is 2 to 6 times higher than Acinetobacter. It also has efflux pumps that are intrinsically turned on at a low level. And then I guess the most important thing is it has a massive resistance island, and there's been up to 45 resistance genes documented in this. And using transposons, basically any resistance mechanism has been documented. Transposon-mediated resistance also allows it to both get ease of acquisition and also transmission of both plasmids and chromosomal-based resistance mechanisms. So together with its ability to develop resistance and its persistence in the environment, the WHO has actually classified this as one of the critical organisms, which is a major threat to human health. If we just target a little bit about beta-lactam resistance, because we're going to focus now on carbapenem resistance. And we do know it has intrinsic class C chromosomal AMP-C. This one, the carbapenems are actually stable against. It can be overexpressed with an insertion element. And then if we look at the types of carbapenem resistance, if we look at the class D oxacillinases, constitutively, it does have OXA51. And again, this can be overexpressed again with the insertion IS element. And then we know there's a variety of different oxacillinases, commonly 23, 24, 40, 58. Some of these are plasmid-mediated, transposon-mediated, which play an important role. Again, weak carbapenemases, but then can be turned on and promoted for overexpression. We also know that Acinetobacter has acquired class B metallobeta-lactamases, although this is less common with NDM, VIM, and IMP, and there also has been a very rare instance of KPC carbapenemase resistance mechanisms. So let's turn to XDR Acinetobacter, which is what the patient had. And there's lots of different definitions, but recently the Canadian Public Health Laboratory Network in conjunction with CABMID came out with a definition. So basically this is when the Acinetobacter strain is resistant to all 5 of Cipro, Piptazo, Ceftazidime, Imipenem, or Meropenem, or Tobramycin, which is what this patient had. If you look at carbapenem resistance from a global perspective in the US, we know there's a very high rate of resistance of Acinetobacter baumannii in the ICU, greater than 50%. And this has also been seen in many regions of the world, in Europe, Latin America, and Asia. And one of the frightening things is that overall, in a lot of these surveillance data, there has been an increase since 2000. As I already mentioned, mortality is very significant, and usually this relates to initial ineffective therapy because of such few treatment options. This is one of the global surveillances. Sentry does a lot of surveillance data. They're usually very robust, large collections of organisms. And what I wanted to highlight is that if you look at this, and this first table looks at it over time, you can see that with carbapenem, meropenem, that the percent susceptibility really has decreased over time. And overall, it's down to 60% susceptible. Even more worrisome is XDR is very common in Europe, less common in North America. If you look at the colistin, and they initially didn't test this early on in the surveillance, you can see that it is reasonably stable and predictable in being mainly susceptible. This table just highlights that there are regional differences globally. And North America is less of an issue, but you can see that even up into 2013, 2016, 40% of isolates met the XDR definition. If you delve a little bit deeper into this surveillance, there actually was 0% of pan-drug resistance in Canada, but pan-drug resistance was up to 9% in Italy. And by pan-drug resistance, this would also include colistin. So if we turn to some Canadian data, and from this study, the CINIF study, where they were targeting carbapenemase producing Acinetobacter species, you can see that the Canadian situation actually is quite different than what we're seeing in global surveillance data. So this looked at treating acute care hospitals from 2010 to 2016, very low national incidence rates, and interestingly, no significant increase over time over this 6-year period. There are regional differences in Canada with the eastern part of Canada, the Maritimes, basically not having carbapenemase producing Acinetobacter, and most of them are from central Canada, which is our area. The epidemiology is a little bit different. You can see that up to almost 40% of cases had international travel, and in those 40% of cases, over 90% actually had medical treatment in a different region. So they're really bringing this in from other countries. They did do some molecular determination, and the common oxotypes were 2, 3, 5, and 23. And 23 seems to be the most common global strain. So the Canadian picture seems to be quite a bit different. This also took a look at some of the other options, and as you can see, for carbapenem-resistant Acinetobacter, Tigus Cyclin and colistin are the two second-line agents that have the best profile. I did look at some of our local data. One of the residents, Dr. Duncan, has been looking at our antibiogram data. And from the period 2018 to 2019, we had 50 non-duplicate patients with Acinetobacter in the Hamilton General ICUs and no carbapenem resistance. So that's sort of reassuring. I then went and pulled some data from 2019 and also the 2020 data for Acinetobacter, and this paints a slightly different story. So certainly in 2019, we had no XDR Acinetobacter baumannii. But in 2020, we actually had 7 non-duplicate patient isolates with XDR Acinetobacter. And unfortunately, all of them were at the Hamilton General site, which is my site, 3 in the ICU. And out of those 7, 5 were sent for colistin with an MIC of 0.5. So let's go back to treatment options. So this is really a nice little summary table by Tama. She's involved, she was most recently involved in the IDCA guidelines for antimicrobial treatment of AMR type organisms. And if you look at carbapenem resistant Acinetobacter baumannii, there are very few sort of foolproof empiric options. One of them is this newer drug Cephaderasol. There is also a new agent, Cephaderasol, which we don't have any access to. Tigus Cyclin, and as you can see, colistin may vary depending on your region. So really you would need to know based on susceptibility testing. But a lot of the other new agents that have come out and are more readily available in Canada, such as Cephaderasol and Tazobactam, really are ineffective against the carbapenem-resistant Acinetobacter baumannii. So I'm just going to talk briefly about some of these second-line agents before I talk about Cephaderasol. So colistin is an old drug. It came in 1960. It is has the advantage of being bactericidal, and as you can see from a lot of the surveillance data globally and in Canada, very low rates of resistance seen in crab. The difficulty with this drug is a few, actually. One, with colistin, it is administered as a prodrug, so it has to actually transform into the active drug. And this is really sort of unpredictable, and it can take several days. So what that means is it's very hard to get an effective concentration of the active drug immediately. And this is especially important if you have a bloodstream infection. Polymyxin B is better, but that's not readily accessible in Canada. And probably one of the other difficulties is the PK/PD data. We do know sort of what the target AUC should be for Acinetobacter, but this really translates to a plasma concentration of around 2 milligrams per liter. And it's very hard to balance giving this drug to reach an effective plasma concentration and balancing toxicity. And in fact, this is a very toxic drug. Nephrotoxicity in adults occurs in around 20 to 50% of patients who receive it. And as you can see from our case, the nephrotoxicity developed very rapidly. CNS toxicity is a little bit more rare, but again, this was one of the limiting side effects for our patient. So really, it took colistin off the table. Numerous guidelines recommend through therapeutic drug monitoring, but this is not readily available in Canada. And I do want to highlight a little bit in terms of the susceptibility breakpoints. Most recently in 2020, CLSI actually revised the breakpoints for Acinetobacter to basically highlight that no matter what you do, it is very hard to achieve effective drug levels. So they removed the category of susceptible. So now there is only the intermediate and the resistant category. The other difficulty is colistin can only be tested using broth microdilution, so there aren't as many options available to clinical laboratories. You're often relying on referral labs. So one of the other thoughts, as you noticed, we empirically started meropenem and colistin at the same time. And a recent survey of ID physicians actually found that this is very common practice. And the reason this is from some of the in vitro data, there has been demonstration of synergy with increased bactericidal effect when you combine the polymyxin along with the carbapenem, even in the setting of carbapenem resistance. There's also in vitro data that this combination may delay development of polymyxin resistance. However, if you look at some of the clinical data, and I'm just summarizing this one study, this was a multi-center study, open label. They randomized meropenem prolonged infusion versus meropenem plus colistin. And it is applicable to our patient because 75% of the isolates were Acinetobacter. Pneumonia was the most common syndrome. And they use, the outcome was a surrogate of clinical outcomes. And if looking at the clinical failure at day 14, they did not really find, they did not find a significant difference between colistin monotherapy versus colistin plus a meropenem with prolonged infusion. And they also did not notice any difference in colistin resistance by day 28. This, however, was a little bit of a limitation in that it was smaller subsets, and they also, when they tried to remove some of the diagnostic sort of grayness, such as a probable VAP, they did find that that the combination had less failure, but this was still not statistically significant. This was an interesting study because it took another perspective looking at if you are using combination therapy of a polymyxin with meropenem versus polymyxin alone, does it have an impact in your amount of XDR Acinetobacter baumannii. And they did a before and after intervention where they actually stopped using combination therapy. And what they found when they stopped is there was a reduction in the isolation of Acinetobacter baumannii in sputum cultures, reduction of XDR, and they were actually able to eliminate their OXA23 strains. If we look at Tigus Cyclin, this again is one of the second line options that's available with reasonable susceptibility data as a good empiric choice. But this is also a really difficult drug. We know it concentrates rapidly in tissue, although it doesn't concentrate as well in lung. And because it concentrates rapidly in tissue, there actually isn't a sufficient level in the serum to be bactericidal. There is an FDA label highlighting that there was an increase in all-cause mortality, and this was based on numerous phase 3 and 4 studies. But this was using a standard dose. And with the standard dosing in the VAP study, they found that there was lower cure rates and higher mortality, especially in the setting of bacteremia. So this is really sort of tempered or limited. This is a limitation of tigecycline. So there are some studies, though, looking at high-dose tigecycline. This one randomized trial actually showed some very small, but maybe some clinical benefit of it. And this systematic review, although it doesn't really answer the question of high-dose tigecycline versus other options compared to standard dose, does seem to have decreased mortality. And I'll just skip the tigecycline susceptibility. So the last drug I want to speak about is Cephaderasol, and this is a new cephalosporin. It's a ceterophore cephalosporin that can bind to iron and uses a Trojan horse approach to enter the bacteria, and Derek will talk about this more. And it basically allows it to bypass the porin channel loss and efflux, which is really important because, as I mentioned, this is an intrinsic aspect of Acinetobacter, which reduces its susceptibility to antibiotics. And it's also very stable against serine carbapentanases and metallo-beta-lactamases. If you look at surveillance data, it looks very effective. A wide range of gram negatives, including Acinetobacter baumannii. And it actually has been approved in the US. It has approval for complicated urinary tract infection, and in September of last year for HAP and VAP. However, it does have an FDA warning because of concerns of all-cause mortality. And this is mainly based on the credible CR study. So this is a randomized open label parallel group. It's a descriptive study, and they specifically wanted it to be a pathogen focused study to look at carbapenem resistant organisms, where they looked at Cephaderasol versus best available therapy. And the primary endpoint was really a clinical cure, secondary endpoint, all-cause mortality. As you can see, it's a very small study because it's very hard to recruit when you're looking at just specifically carbapenem-resistant organisms. And I'll just show you the next two slides. The clinical cure rate, basically, if you look at overall or by the different syndromes that were treated, there was no significant difference in clinical cure rate. And remember, this is more of a descriptive study. Although there may be a better effect in the enterobacteriales with metallo-beta-lactamases and maybe less relapse. But what was concerning to the FDA was that for whatever reason, there seemed to be an increase in all-cause mortality. Now, this was a secondary endpoint, so they weren't able to randomize based on Apache score. So the different groups had different severity levels of disease, and this was seen in the Cephaderasol arm having higher admission to ICU and higher renal dysfunction. But the concerning part is, why did this happen? Acinetobacter baumannii, 49% mortality in Cephaderasol versus 18% in BAT. There's some concern that this 18% overall is much lower than any other study, but something that can't be explained at this point. So the post hoc analysis showed that over 6.4 more deaths at day 28. The only other study I want to present, and this was published in the same journal, is the APEX study, which looked at pneumonia specifically caused by gram-negative pathogens. They were supposed to exclude carbapenem-resistant organisms if you knew that before enrollment, but in fact, a lot of patients were enrolled that were carbapenemase producers. It's up to the clinician to decide whether they stayed in the study. And the bottom line with this one, its primary endpoint was all-cause mortality, so they were able to randomize based on Apache score, and there was no difference found. And this is just a summary of that. Cephaderasol susceptibility testing is quite difficult because of the iron aspect, and I won't go into it that much further. To sort of summarize is that often with new antibiotics, breakpoints evolve. And so you can see the investigational breakpoints from CLSI, which are only supposed to be used for research, modification in the FDA, and of course, UCAST is different. Bottom line, in our patient, it was susceptible. So in summary, this patient had a very complicated course, but she did receive cephaderasol for almost 3 months, and she has had resolution of her osteomyelitis due to the XDR Acinetobacter baumannii. Obtaining cephaderasol, though, is very difficult. It requires SAP application, a legal document for release from the company Shionogi, probably because of the FDA warning, and written patient consent, almost like you're enrolled doing a clinical trial. Emphasizing that globally, XDR and PDR are an increase, although less common in Canada. We're still relying on second-line agents, and that's why this new siderophore cephalosporin, cephaderasol, is really quite promising. The only thing, there's a few things that need to be resolved. Whether or not there really is an increase in all-cause mortality, susceptibility and clinical breakpoints to help guide us better. And then it just highlights the essential aspect of drug development to combat AMR. And I'm just putting up these, which everyone would be familiar with, the Canadian document about when antibiotics fail, WHO. And with that, sorry, I talked a little bit too long, but I'll let Derek now carry on in terms of that very important aspect of drug development.
All right, hopefully everyone can see my screen. And thank you very much, Deb, for that great segue and your talk as well. So yeah, I'm going to talk about how we can actually develop new antibiotics for Pseudomonas as well as Acinetobacter. And we're going to do this by exploiting iron to deliver antibiotics. So as Deb mentioned, the World Health Organization in 2017 actually made a list of pathogens where new antibiotics are needed because many of them are becoming resistant to existing ones. And they placed them into 3 different categories or priorities, them being critical, high, and medium. And we can see that Acinetobacter and Pseudomonas are in the critical priority. So it's most urgent. And the one I'm going to focus more on is Pseudomonas, just because that's what our lab works on, and we use that as a study organism. So Pseudomonas is involved in infections from cystic fibrosis patients, as well as burn wound infections, as well as medical device implants. And because we have so many medical device implant surgeries, Pseudomonas is definitely a pathogen of concern. So the main difference, if you look back on this list, majority of these bacteria are gram-negative bacteria, and you have a couple of gram-positive like Staph aureus. But the main differences between the physiology of the 2 bacteria is basically their cell wall. And in gram-positive bacteria, you have this very thick peptidoglycan layer. But this peptidoglycan layer, while it's very thick, it's actually very porous, and you can have antibiotics like vancomycin that can actually inhibit the growth of these gram-positive bacteria. On the other hand, in gram-negative bacteria, you have, even though a very thin peptidoglycan layer compared to a gram-positive bacteria, you actually have the presence of this outer membrane. And this outer membrane provides additional resistance to many antibiotics, which is why antibiotics like vancomycin actually have a very hard time crossing through. So how do we actually get antibiotics through gram-negative bacteria? Well, for example, cephalosporins like ceftazidime, they typically can go through this porin called OPRD in Pseudomonas. And this porin allows for passive diffusion of antibiotics into the cell, and this doesn't require any energy. As Deb mentioned, one of the main problems, however, that overlaps between Pseudomonas and Acinetobacter is the expression of OPRD. So you can actually, or bacteria can actually reduce the expression of OPRD, and this would lead to a decrease in the amount of bacteria that can actually get inside the cell. Thus, you would get an increase in MIC. However, with cephaderasol, it has this extra way of getting inside the cell, and that is through these TOMB dependent receptors. So cephaderasol is also a cephalosporin. It can also go through these OPRD receptors, porins, sorry. But if there is a reduced expression of OPRD, it can actually also go through TOMB dependent receptors. And you can see from this diagram that TOMB-dependent receptors and porins are architecturally very different. So these TOMB-dependent receptors are not open channels, they're actually closed. And in order for something to get in, a ligand specific for that receptor has to bind to the surface towards the extracellular side. And then through TOMB mediated active transport, then you could actually, the receptor will open and then drag the antibiotic in. So cephaderasol is actually a combination of cefepime and ceftazidime, and I've highlighted the residues that are similar between all three of them. And you can see ceftazidime here, this blue residue, and then cefepime, this yellow residue. And these two parts may provide additional stability against beta-lactamases, as well as reduce recognition by those beta-lactamases and increase permeability through the outer membrane. But cephaderasol also has this extra catechol or chlorocatechol moiety, and this is the part that binds iron and is recognized by the TOMB-dependent receptors. So this catechol moiety, if you actually alter it, instead of having a catechol and you have a methyl group, it actually loses ability to cross through these TOMB-dependent receptors. In Pseudomonas, cephaderasol actually crosses to two main TOMB-dependent receptors, being PUA and another ortholog called PUD. There's also other ones involved, but I won't go through all of them because there's actually 34 TOMB-dependent receptors in Pseudomonas, and there's about 20-ish in Acinetobacter. And so one way you can actually get resistance to cephaderasol is by having a mutant that can't make PUA. And there's about a 16-fold increase in MIC when Pseudomonas is lacking PUA. But these TOMB-dependent receptors, their main role is actually for uptake of iron, vitamins, carbohydrates, and even other metals like copper and zinc. Iron seems to be the most predominant reason why there's actually TOMB-dependent receptors. And in fact, majority of the receptors in Pseudomonas are iron regulated. So I'll go through some of those. So here is a streak plate of Pseudomonas, and you can see the colonies that are tightly packed, some are single colonies. But if we look around it, we can see this very fluorescent halo. And this fluorescent halo is actually due to the production of a compound known as palovaradin, which I have the structure over here. And you see the structure is also a very big compound. But what's important is that when Pseudomonas is grown in iron-limited conditions, for example, at sites of infections, Pseudomonas will actually produce this palovaradin molecule. And palovaradin belongs to a larger group of molecules called siderophores. So siderophores are basically bacterial metabolites that bind iron. And you can see that the palovaradin is secreted outside the cell, and it actually diffuses away. And eventually, some of these palovaradin molecules will encounter iron and bind iron, and then will actually return through the cell through the TOMB-dependent receptors that I showed earlier. Because Pseudomonas has 34 different TOMB-dependent receptors, some of these are actually even involved in the uptake of siderophores produced by other bacteria. So here's just a schematic of palovaradin going through the TOMB-dependent receptors. And in Pseudomonas, there's actually two TOMB-dependent receptors for palovaradin, one of being FPV-A and FPV-B, and it's just denoted by ferry palovaradin, so FPV. And so why is this important? Palovaradin is actually one of the most highly expressed, or the receptors for palovaradin is one of the most highly expressed TOMB receptors in Pseudomonas. And we actually accidentally stumbled across a drug or a compound that could actually hijack the FPV-A and B receptors that are for palovaradin. So I'm just going to go into how we actually discovered that by accident. So what we were originally looking for was biofilm stimulation or biofilm formation in Pseudomonas. And so Pseudomonas is also a model organism for studying biofilms, but we can think of growth of Pseudomonas in two different ways. One of them being planktonic growth and the other being biofilms. And planktonic growth, we can think of it as bacteria, they're able to move around in the liquid media and not adhering to any surfaces. Whereas a biofilm, we can think of it as cells that are adhered to a surface, kind of like a plaque on your teeth. And these these biofilms are basically communities of bacteria encased in a matrix, and this matrix actually protects them from external threats like antibiotics. And so antibiotics have a hard time getting through the biofilms. However, if you treat cells with a low concentration of antibiotic, not enough to kill them, or inhibit growth, you actually push the growth towards a biofilm lifestyle. So we actually get more biofilms. And so we ended up screening 4,000 compounds looking for growth planktonically as well as biofilms. And we found that this compound called thiostreptin had some very weak planktonic growth inhibition as well as very strong biofilm stimulation. And so thiostreptin is a thiopeptide antibiotic that has been shown to have very good activity against gram-positive bacteria like Staph aureus, but in gram-negative bacteria, it rarely has any significant inhibitory effects. And the main reason is because people thought that this antibiotic couldn't even get across the other membrane. So if we look at planktonic growth, we actually measured planktonic growth and biofilm stimulation for thiostreptin in a dose response assay. So here is just percent of control. And then in yellow, we have planktonic growth, and purple, we have biofilm, and with increasing concentrations of thiostreptin. So you can see that towards the highest concentration of thiostreptin we tested, there is some weak growth inhibition, but we see very significant biofilm stimulation, about 1,000% of control. And if we add iron back into the media for the same dose response assay, the amount of growth inhibition we see is less. And also for the biofilm stimulation, we also see a reduction. So it's now about 500%. So this suggested that thiostreptin activity against Pseudomonas was in fact iron dependent. And this kind of led to the thought that if we combine iron chelators with thiostreptin, then we might see a synergistic effect. So here are checkover assays that I did with Deferocerox, as well as this antibiotic doxycycline. And so Deferocerox is a iron chelator, and you can see in this checkerboard assay is basically showing the effects of both of these compounds, thiostreptin and Deferocerox, against Pseudomonas, and we're monitoring the growth. So the darker purple means that you're getting more growth, and in white it means you're getting no growth, and white is basically what we want. So you can see in the first column where we have thiostreptin alone, we don't really see that much growth inhibition. And at Deferocerox alone in the bottom row, we actually don't see much growth inhibition as well. But if we look diagonally, when we have combinations of the two compounds, we actually see very strong synergy between the two. And this translates towards doxycycline as well, because doxycycline can also bind metals. And we've also tested other iron chelating agents, and those agents also synergize with thiostreptin. Also, we've even tested thiostreptin in serum. Serum is known to be very iron limited. And even without any additional chelators, you can actually get very potent activity of thiostreptin in serum. So we're wondering how thiostreptin gets inside the cell, right? And one of the ways we investigate this was actually by testing thiostreptin against mutants that couldn't make the palovaridin receptors. And so remember, there are two receptors for palovaridin and Pseudomonas, A and B. And we tested thiostreptin against wild type and mutants. So in our wild type PA14, it can make both of these FPV-A and FPV-B receptors. And we got an MIC of 1 microgram per mil in very iron limited media. And then we have a transposon mutant that can't make FPV-A. So now there's only one way for Pseudomonas to get inside, for thiostreptin to get inside Pseudomonas. So that brought the MIC up 13-fold, which is quite significant. However, if we have a mutant that can't make B, but can make A, we still see a slight increase in MIC, although not that significant. And then in a mutant that can't make A or B, then we see that 13-fold increase again. We also tried complementing this mutant with a FEV-B again. So we obviously have our empty vector control, and our empty vector control is the same as just the mutant that can't make both receptors. And then we have our empty vector with the FEV-B gene on it. So now this Pseudomonas can make FEV-B. And then the MIC is reduced back to similar levels as the mutant that can make FEB. So these results suggested that thilestreptin requires the pyruvate receptors to get inside the cell. However, you can see that if we lose a receptor, or if Pseudomonas can't make one of the receptors, we do see an increase in MIC. So I was wondering whether or not we could actually find other thiopeptides that belong to the same family as thilestreptin that could hijack other receptors beside the pyruvate receptors. So we're covering more of these TOMB-dependent receptors rather than just relying on 2. And so what I did here was I took 9 thiopeptides and I tested them for synergy with the Firacerox. And of these 9, 3 of them actually synergized. And then I took these 3 combinations and I tested them against the mutant that can't make either of the pyruvate receptors, so it can't make A or B. And the reason I did this is because if the combinations had activity against this mutant, that means that the thiopeptide may use a different receptor. So we actually found 2 of the 3 that had activity, and this thiopeptide is called thiocillin. And there's another structural analog that's very similar that I won't talk about, but I'll focus more on thiocillin. And so because we had activity for thiocillin against that mutant, we were wondering what receptor does thiocillin actually go through. So we tested 16 transposon mutants, each with an insertion into a TOMB-dependent receptor. And then we found out that this FOXA mutant, or a mutant lacking FOXA, was actually resistant to thiocillin. So FOXA is FOXA is the receptor for the siderophore called ferrioxamine. If you remember it, I mentioned that Pseudomonas has 34 TOMB-dependent receptors. So it's able to actually take up siderophores from other bacteria as well. And ferrioxamine, which I have the structure over here, is a siderophore produced by Streptomyces species. And so here is just a dose response assay of thiocillin against PA14 wild type, and we're looking at growth. So thiocillin alone in the blue dots doesn't really have much of an effect. However, once we combine it with the Firacerox, we get an MIC of about 3 micrograms per mil. If we have a mutant that can't make FOXA, then even if we add the Firacerox, then we actually don't see we don't really see growth inhibition at all, showing that FOXA is definitely, or is likely, the receptor for thiocillin. And we can actually complement this on a plasmid. So now a complemented strain is still has a transposon insertion into FOXA, but now it can make FOXA through a plasmid. And you can see that we restore growth inhibition when we add the Firacerox, whereas with thiocillin alone, we don't see growth inhibition. So this was pretty, this showed that thiocillin requires the FOXA receptor to get inside the cell. And we also tested the combinations against clinical isolates of Pseudomonas and Acinetobacter. So here I'm just going through the clinical isolates of Pseudomonas first. And we tested 96 clinical isolates of Pseudomonas. So you can see that when we tested the thilestreptin against the 96 clinical isolates, there's actually a wide range of inhibition. So some that are susceptible, and then some that are somewhat inhibited, but then some that are, again, resistant. When we add the Firacerox to thilestreptin, most of them actually become susceptible to the combination, although we have some that still grow. And this one especially is resistant to the combination. And it's actually the same one as this one over here. We also tested against Acinetobacter. We had fewer isolates of Acinetobacter, so we only had 10 clinical isolates. And one of these, so this one here, is actually a ATCC strain. So what we wanted to focus on was this very resistant clinical isolate against thilestreptin to Firacerox, and we wanted to know whether it was actually sensitive to thiocillin, because thiocillin uses the FOXA receptor instead of the pyruvate receptors. And what we found was a very similar trend with our wild type Pseudomonas. So thiocillin alone doesn't really have much inhibitory effect. However, thiocillin with the Firacerox, we get that MIC of around 3 again. And what's interesting for Acinetobacter, although we didn't test thiocillin with these Acinetobacter clinical isolates, majority of these are susceptible to thilestreptin to Firacerox. And it's funny that the ATCC strain, which is not a clinical isolate, compared to these ones at least, it was actually resistant to Thalasstreptin plus Diphtheria sirax. And this shows that there's a very heterogeneous response to antibiotics between lab strains and clinical isolates. So that's why it's good to test both. And so just to summarize, we've shown that Thalasstreptin can hijack the palovaradin receptors, FPV-A and FPV-B, which are for palovaradin again, to get inside the cell. We showed that Thalacillin can also hijack the FOXA receptors for ferrioxamine. And these antibiotics are very similar to Cephaderasol, where Cephaderasol can hijack the TOMB-dependent receptors. So these are interesting avenues to explore, and potentially they can be used for using the clinic against Pseudomonas and Acinetobacter. We still don't know how these antibiotics actually get through the inner membrane once they cross the outer membrane, and that's something we're still working on. And what's interesting is that there's potential to conjugate either Thalasstreptin or Thalacillin with the other antibiotics. So you'll have dual antibiotics, and then once that gets inside the cell, it may release two different antibiotics and inhibit growth. With that, that would conclude my talk, and I would like to thank my supervisor, Dr. Lori Burrows, as well as other Burrows Lab members. I'd also like to thank Mike and Irene, who are previous students working on the project, and well as my supervisor committee, Lori, Jerry, and Marie, and as well as our funding sources. And because I have a bit of time left, I want to leave this off with another experiment that I did. So we've shown that we've shown that Diphtheria sirax can synergize with Thalasstreptin. So what if we put Cephaderasol and Diphtheria sirax? Interestingly, we actually see antagonism compared to with Thalasstreptin and Diphtheria sirax. So even though Cephaderasol can go through TOMB-dependent receptors, its activity is not necessarily better when we add iron chelators with it. So again, yeah, thank you very much for listening.
Thank you, Derek. And thank you to Deb too. Those were both fantastic talks. So we're going to now go to the Q&A. And if you have questions for either of the speakers, please type them in and I will read them out. So the first question is from Jerry. There are a few Abelmanii narrow spectrum drugs in the pipeline. Would you and your colleagues use such narrow spectrum drugs? Lots of discussion in the discovery community of infectious disease, or whether infectious disease physicians are comfortable with using such targeted therapies. So I guess, Deb, that would be for you.
So I think it depends on what stage you're assessing the patient, deciding on therapy. Obviously, if it's empirical when you're doing it syndromically, you wouldn't want to. But in a patient similar to this one, where you do have good tissue cultures and a very specific organism, then yes, you would want to use a narrow spectrum drug, especially if you also are not going to then have an impact on the antibiotic community or within the gut or in the environment, if it can be targeted to that organism. So I think it really depends on where you are in your clinical diagnostic framework for treatment. Unfortunately, in infectious disease syndromes, we often do not get an organism. So then that would limit it in terms of not wanting to use narrow spectrum drugs. So it also, I think, is tied into having good diagnostics.
Yeah, that reminds me of, it's the same argument for using phage therapy, right? You really need to know specifically what's going on before you can come up with a treatment. Okay, the next question is from Hindra, who compliments you, Derek, on your fine talk. He wants to know, what are the general requirements to have conjugation between siderophore type molecules and potential antibiotics?
Yeah, thank you, Hindra. So one of the concerns that we have is if you conjugate an antibiotic to a siderophore antibiotic, will it be unable to use the receptor to get inside the cell? Because now you're changing the shape of the molecule and you're making it bigger, right? You also have to consider about whether or not the two antibiotics will dissociate once they're inside the cell, and whether or not they could still bind their targets if it's a single molecule, or if it can even dissociate at all. So I would say those are some considerations that we would have.
Derek, I have a question for you about the potency of these thiopeptides against gram negative. So do you think the MICs that you're getting are what they are because the drugs are, because you're actually measuring how much drug is being taken up as opposed to how potent they could be if you were able to increase uptake even further?
So you're saying that the MICs could be possibly lower, is that what you're trying to say?
Yeah, so I'm asking, are the MICs 3 micrograms per mil because that's the maximum amount of drug you can get into the bacteria using these TONB dependent receptors? Or is it just a function of they're not very potent against gram negatives, period?
So with alstrictin, the MIC actually, there's a range of MICs depending on the amount of iron available in the media. So if there's low iron, then we can actually get an increased MIC. We've done it in serum. So in serum, we've actually got MICs in the high nanomolar range. So I think it is partially more of an uptake problem rather than a activity.
So how would you address that from a I guess developmental perspective? Because I know one of the major issues with these compounds is they're not very soluble, and you can sort of partially overcome that by reducing the iron concentration, so you improve uptake. But are there other things you think we could do to improve their potency?
I think we could even look at possibly structural analogs, because we haven't done any SAR. Right, we're still using what's naturally made by the bacteria. So I think there's still avenues for there to explore.
I think Mother Nature may have attempted some of those avenues already, but they are big, ugly molecules.
Yeah, they are.
Any further questions? Deb, I actually had a question for you about the colistin susceptible versus intermediate, but I think you sort of answered that along the way, because I noticed your early 0.5 mg per mil was considered susceptible, but later it was not, it was considered intermediate.
Yeah, and I was hoping to go back to that, but yes, that reflected the when public health changed their breakpoint interpretation based on the updated guidelines in 2020.
Is that just for Acinetobacter, or was that for other drug resistant?
Yeah, no, it was for other organisms too.
Wow. Okay, I have a question from Luke. Are there any special contraindications for iron chelating drugs with respect to infections? Would these drugs, such as Cephaderasol or Deferoxirax plus antibiotic, be appropriate for patients with anemia from chronic infection?
So from the clinical trial data, they actually did look at whether it had an impact on iron metabolism or any of the laboratory markers, and they did not see any effect with that. So at least from these initial studies, it does not appear that it will impact the patient who has low iron to begin with.
Yeah, actually, the one thing that you said that really struck me was that the defining the breakpoints for new antibiotics like this with new modes of activity is a whole area of science in itself, right? So how do you, when you're used to doing susceptibility testing in rich media like Mueller-Hinton, and now you have to consider low iron to understand what the drug is actually going to do in the patient, that's a whole area that needs to be developed.
Yeah, and the low iron in the for the broth microdilation panels is very specific to Cephaderasol. And it's very tricky because, as we all know, whether in research or clinical, you can always get an MIC, right, from any method. So the method itself then has to sort of be correlated to PK/PD and clinical effect. And it is interesting that for Cephaderasol that they are saying if you're just doing standard Curie-Bauer, you can just use regular Mueller-Hinton. They didn't think it was the concentration iron would have an impact, I think because of diffusion aspects, but we did do Kirby-Bauer testing for the Cephaderasol, and we got this inner zone of organisms. And so I was very curious when the reference lab did broth microdilution with the appropriate, iron deplete media, they actually got an MIC that was fully susceptible. So I think it is a little bit tricky, and usually with these sort of things evolve as you get more clinical data and more clinical lab experience.
Cool. Okay, one last question since we're out of time is from Ikram. He says, Derek, have you observed a change in the TUNB-dependent protein expression profile of Pseudomonas over prolonged use of iron chelators and thiopeptides?
Oh, we haven't actually looked at the expression profiles yet, but it is known that iron chelators and even iron-limiting environment will increase the expression of these TOMB-dependent receptors. The amount of expression the amount of expression actually depends on the receptor itself. Some of these are more expressed highly in Pseudomonas, for example, the pyruvate receptors, whereas other xenosiderophore receptors, so TOMB-dependent receptors for other siderophores, those tend to be expressed at a slightly lower level. And then other receptors for other metals are even lower. So it really does depend. Okay.
I'm going to say stop it here since we're out of time and say thank you both for great talks. And thank you everybody who's listening. And we will see you next month, first Wednesday in March, same time. Stay safe, everyone.